So today we're going to review the management of pain, agitation, and delirium in the ICU. So I've tailored this talk to be more focused on MICU patients. Just be aware that there may be some facets that pop up in some of the screenshots I've taken from the new guidelines that address like epidural, so on and so forth, that we're not necessarily going to routinely discuss here. So objectives: to review causes and therapy of pain, agitation, delirium, which you'll see as PAD from here on out in the ICU. That's actually a new coined mnemonic for pain, agitation, and delirium in the new guidelines. We'll review and interpret the 2013 clinical practice guidelines for the ICU management of PAD. Okay. I will tell you that there will be some variances between what we do now compared to these guidelines. Okay, so be ready for some, perhaps some suggestions and some considerations for the future. Before I even go on, one thing to consider: anybody have any idea when the previous guidelines were published? 2013. We've been waiting for a while. Any guess?
2006.
Even before that?
98.
Well, the data was from 98, but it was 2002. 13, yeah, 11 years. 11 years of data. And a lot of that data was from 1996 through 1999, maybe 2000. So old. We'll talk about some of the validated tools that we use. Some of them will be very familiar, others will be new, and then discuss methods and benefits of reorientation, as that tends to be the future. So looking back here, this is Curtis Sessler. Some of the work that he has done. He's a name that is synonymous with management of these disease states. As you can see here, it's very straightforward and easy. There isn't a whole lot going on when it comes to the complex of pain, agitation, and delirium. And when I say easy, I'm being incredibly sarcastic because we have everything from the underlying medical conditions, in which ICU tends to take the crown for that one, right here. Right? Medications, which ICU tends to have the highest number of medications, right here. Okay. Hospital-acquired illnesses. ICU environmental influences. As you can see, there are a bulk that lead to the triad of anxiety and pain and delirium. As you can see, they're all here set on the same pedestal because they are all interrelated. You'll see that on the next slide. So here we're going to talk about interventions and management of predispositions and causative conditions. And as you can see, we're talking about sedative, analgesic, and antipsychotic medications. Now, the one thing that I will criticize this about is the order should be changed. As you can see, PAD as pain, agitation, delirium is put in order purposefully. So I'm going to be kicking one horse so many times today, is that, and many of you have heard me say this, it's always pain. Treat pain before sedating the patient. Because guess what? A sedated patient still feels pain. And that is a topic that many of our physician colleagues, residents, up through fellows, up through attendings, miss at times. And as you can see, there is a spectrum of how well those interventions can go. As you can see, far to the right is unresponsive. So here we use Richmond Agitation Sedation Scale, right? And I will talk about that a little bit later. But as you can see, this is literally from right to left as you go from unresponsive to dangerous agitation. That is going from a RASS of -5 to a RASS of +4 in the range that we use. So everything from lightly sedated, which is generally you're going to find is the goal, deeply sedated, unresponsive, all the way up through wanting to rip our larynxes out. So as I told you before, they are all related to a certain degree. Now, I will tell you this slide is somewhat historical. This is something that many of my colleagues have presented on for years, upon years, well prior to these new guidelines. And while I have delirium as the tip of the pyramid here, I will tell you right off the bat that the delirium updates in the most recent guidelines were the most profound, because there's been the most literature, most data done in delirium management in the ICU since the last update. So it's probably more of a box, maybe a little bit more of a cone instead of being just a straight up pyramid. And as you can see, a large part of this, even though I'm here as a pharmacist, I think a few of you have probably heard me say that drugs are bad, because they are, right? And I have another presentation, drugs are bad. So non-pharmacologic interventions do play a huge role in this. Then if you look to the right of the slide, as you can see, they are all interrelated, right? Pain can lead to anxiety, it can lead to delirium, it can lead to agitation. And consequently, if you have somebody who's agitated and delirious and they're flopping all around in the bed and they have a reason to be in pain, it becomes a vicious cycle. Okay, so these arrows can go virtually in every direction back to one another. Okay, none of it is in our favor, More importantly, none of it is in the favor of the patient. So management is incredibly important. So we're going to start off with pain. So definitions. The International Association for the Study of Pain defines it as an unpleasant sensory or emotional experience associated with actual or potential tissue damage. That's going to be key. Or described in terms of such damage. Several studies have been done in critically ill patients to identify pain as one of the greatest stressors. To the point, you can see the statistics here. These are just two examples. 82% of patients remember pain or discomfort with endotracheal tube. All right, I don't think many of you would be surprised by that, right? We're not designed to have a piece of plastic thrown down our trachea. No way. 77% remember moderate to severe pain during the ICU stay. Now, is the goal 0? Probably not. It's not realistic, right? It's not realistic. Plus, there are 7 of us in this room, and I will say that my definition of 10 out of 10 is different from Barb's definition of 10 out of 10. Okay, no question about it. I guarantee you she has a much higher pain tolerance than I do. Now, that being said, this is also associated. How big of a problem is this? Well, there's more and more literature coming out to suggest that just the pain incidence alone, right, just the pain incidence alone has been associated with ICU post-traumatic stress disorder, okay, leading to marked increases of admissions and diagnoses from that alone. Okay, some cases lasting years. So, and remember, this is important. ICU patients, this is straight out of the guidelines, routinely experience pain, even at rest. Okay, so I tend to exaggerate things from time to time to make a point. And one thing that I stress is when you walk by that patient who's been in that bed for 2 weeks, 3 weeks, 4 weeks, or 360 days, they may not look like they're working too hard. In reality, when you compare how catabolic and how high their general stress requirements are, so on and so forth, they are a patient. You're looking at them. I'm not a guy who's particularly well in shape, but if I went out and I decided to run a marathon while doing like Arnold presses or shoulder presses at the same time, I still would not have the same type of level of stress and pain that our patients do. Okay, maybe pain would come close given my waistline. So it's just something to consider. Even at rest, they will be experiencing pain. So what about some sequelae of uncontrolled pain? Now some of this goes back to that diagram I had before, but agitation, okay? Stress response, you can see increased catecholamine surge, right? We see that routinely. So unfortunately it can build upon itself. So you'll see tachycardia, increased systemic and pulmonary vascular resistances. So now we're talking about vasoconstriction, increased myocardial oxygen consumption. I will tell you that one's somewhat debatable, however, in general, if you have a persistent tachycardia, you are going to have an increased demand of oxygen. Hypercoagulability, no question. Immunosuppression, this is part of the facet that you will find that most of our patients, if they're critically ill, they are immunocompromised by definition. Okay, and this is one of the contributors to that facet. Persistent catabolism, you are breaking everything down, and pulmonary dysfunction. Again, leading back to just pain with the endotracheal tube, plus the generalized discomfort of having air blown into you, as keep in mind, we were designed to suck in air, not have it blown into our chest cavity. So pain assessment, what you're going to see here, if you see down there in the lower right-hand corner, Barr, J et al., Critical Care Med, 2013, this is going to be the most common reference that you will see, okay? This is the new guidelines, all right? This is a reference to the new guidelines. So along the way, you're going to see some of these where I've written a letter and a number behind the bullet point. That is basically grade criteria, basic A being a high level of evidence, B being moderate, C being poor level of recommendation, and then as the pluses or minuses go, that's more of a consensus and also strength of the evidence. So for example, a +2 stronger than a +1, so on and so forth. So I don't think this is going to surprise anybody. Routine monitoring of pain is recommended. Now this is going to be the one area where we currently differ, and this is the one area that I would say that maybe in the future we have to consider a practice change. We'll have to see. Utilize the most valid and reliable behavior scales in patients who are unable to self-report, which is most of our patients in which we're trying to manage, right? And that have intact motor function. Sometimes we don't even have that. The game changes when we don't have that. The two scales that the guidelines recommend are the behavioral pain scale and the critical care pain observation tool. Now, has anybody in this room ever heard of either one of those? Yeah, see, so they're up and coming. I will tell you, the behavioral pain scale has been one that's been studied in the mid-2000s. Some of the original papers coming out in 2005, 2006, originally in intubated patients. Critical care pain observation tool. In the guidelines, there is a figure of institutions and what they use. And what they're trying to do is, number one, there aren't a whole lot of institutions that use this. It's fairly progressive. But what they're getting away from is the final bullet point. Suggests against vital sign or observational pain scale use alone. Okay, so what do we do right now? That bullet point, right? Now that being said, you can still use those vital signs as cues for further assessment. Okay, so this may be an area to look. What is the behavioral pain scale? Well, this is from a study done by the French across the pond in 2009 in intensive care med. What they were trying to do was come up with a validated way in non-intubated patients. So that's what you see on the right are non-validated patients. But on the left is probably what we would focus on. We could utilize this in both series of patients. But the score goes, as you see at the bottom, from 3, which is no pain, to 12, which is maximum pain behavior. As you can see across the top, it goes 1, 2, 3, 4, and then there are 3 categories. So that's where you get a 1, or 1 for each, so a 3 across the board, up to a 4 for each category. 4 times 3 is 12. So it runs anywhere from facial expression on both sides, something from relaxed to grimacing. Okay, so still perhaps somewhat outside a great determination, a little bit more objective. Movement of upper limbs, no movement all the way to retracted in opposition to care. Okay, and then lastly, compliance. For those that are intubated, compliance with ventilation. So this could be as much of a pain issue as it can be sedation. Okay, this comes back to why you still should focus on pain before and as much as you would sedation itself. And then the difference with non-intubated patients is vocalization. They tell you, I'm having no pain, to, as you see, I love this, howling or verbal complaint included, such as ow, ouch, or breath holding. So, you know, if worse comes to worse, you hold your breath until you get a dose of drug. It may work. And then, what is considered significant? What is considered significant is when a pain, the BPS is greater than 5. Okay, so think about that. When you look at the left side, which is where this is probably most applicable potentially for our patients, BPS greater than 5 doesn't take much, right? Doesn't take much. Okay. Now the good thing is a lot of this would be non-stimulating. Okay, so I feel like when we go around, we do a pretty good job with this. We do a pretty good job with this. I don't see many of our patients grimacing. Okay, I don't see many of our patients even fully tightened. Okay. Now ventilation, it could be a mix of sedation and analgesia. I will tell you that we do have patients from time to time that we're able to control ventilation. There's no question about that. May not be pharmacologic. That's the downfall of this scale. That's the downfall of some of those scales is it could be a mucus plug, right? It could be infection. There could be something else going on that makes the compliance difficult. But unfortunately, that would still get a 4 because this tool in intubated patients is validated. It is validated, or would be recommended in the guidelines. And then you can see again movement of the upper limbs. It doesn't take a whole lot, right? It takes 2 2s and 1 1. That's it to get a 5. Now you need to be greater than 5. So all you have to do is be on the lower end of all 3 scales, 2, 2, and 2. You're considered to be in pain. So this was an eye-opener for me when I first looked at it, but I thought I would share. So analgesic therapy. Notice what I have up top, even as a pharmacist, non-pharmacologic, and it's what they call relaxation therapy. Probably use it for ourselves too. Proper positioning in bed. Okay, so an example is you could throw this in there with injury stabilization as well. If we happen to have patients with fractures, if we have patients with large decubitus ulcers, so on and so forth, that can be painful if they're laying on that, or if they have any type of nerve-mediated sensation based on orientation. We can help them get in a better position so they're in less pain. That also goes away with eliminating irritating physical stimulation. Or sometimes vocal, I suppose, as well. I say that somewhat jokingly, but it is true. So what is this? Sometimes that's just like we talked about in the last meeting. Do we need that lining, right? Do we need that lining? Do they need to have that IJ sticking out of their neck right now? Do they still need it, right? That's irritating physical stimulation, no question about it. I look at that and I say, God, if I ever get to that point, I hope we have better technology that I don't need to have a line in my internal or external jugular. It doesn't look pretty. And the pharmacologic, what the guidelines do is they do a great job of breaking it down into 2 categories. Opioids, which remain mainstay, and non-opioids, and those are some of your examples up there. Ketamine, NSAIDs, acetaminophen, gabapentin, and carbamazepine. They all make it in the guidelines. So treatment, okay? Preemptive therapy. Preemptive therapy. Trying to predict where you can are non-pharmacologic interventions prior to the invasive procedures. So examples here is we have a young patient right now with multiple chest tubes. If you're going to remove a chest tube, give them a little bit of analgesia, okay? Give a little bit of analgesia. If you're going to put in a Swan-Ganz catheter, right, relatively invasive, very invasive, give them a little bit of analgesic therapy, okay? We think about it when we intubate patients, right? And there are other areas where we could probably encourage thinking about that, because preemptive pain control, if you get the drug working while the pain would set in, can help relieve some of the long-term implications of pain. Intravenous opioids are still the first line of choice for non-neuropathic pain. That's important. Non-neuropathic pain. They are all, this is different compared to what it used to be in the 2002 guidelines. They're all considered to be equally effective as long as you're titrating to similar pain intensity points. Okay? What does that mean? Well, keep in mind, morphine is not as potent as hydromorphone. Okay? It's 5 grades of differences. So 1 milligram of hydromorphone is equivalent to 5 milligrams of morphine. Okay? So in that sense, what's it saying is, well, don't expect to get the same result from 1 milligram of morphine as you would with 1 milligram of hydromorphone. Okay? Non-opioids can be used to decrease or even eliminate the use of IV opioids. So this is, where does this come into play? Your NSAIDs, where they're appropriate. Now, NSAIDs were somewhat limited in our populations here because of acute kidney injuries, chronic renal insufficiencies, GI bleeds, so on and so forth. But acetaminophen can come into play. There's a reason why drugs like Percocet are marketed, right? I do not get paid, by the way, by any company. But oxycodone and acetaminophen, right? Hydrocodone and acetaminophen. They're there because they have been shown that in combination you have a synergistic effect and can reduce the amount of opioids, right? You reduce the amount of opioids, you reduce the sequela from opioids, such as respiratory depression, CNS depression, constipation. All these are things that we look at in our patients every day. And then gabapentin or carbamazepine are considered to be the go-tos for neuropathic pain treatment. Okay, you'll see that we do use, I say here we use gabapentin a lot more. I will tell you as a pharmacist, I prefer gabapentin quite a bit more. The only time I will step out of these 2 drugs is if a patient is taking another agent at home that works for them, right? You have the drug pregabalin, brand name is Lyrica, very similar to gabapentin. Other people take propenerol or Requip. You may see that from time to time. That's more for restless leg syndrome, but can sometimes be used for other neuropathic mediated pains. So sometimes you also have to figure out what works well. Understand I'm making those recommendations outside the guidelines. But if you have something that already works for the patient at home, don't always reinvent the wheel. Sometimes reinventing the wheel ends up in not something circular. That's all I'll say. So here are some of your drugs. The 5 probably most prominent opiates, fentanyl, hydromorphone, and morphine, which clearly those are the ones that we use most frequently by miles. Methadone, and then Remy. Remy's on here because this is straight from the guidelines. Some institutions are using Remy even outside the OR. Why? Because of the metabolic pathway, which is hydrolysis by plasma esterases. So what does that mean? As long as you have plasma, which I hope we all do, we will metabolize the drug. Also, it's very short acting. Shortest acting out of the list. It's the most potent out of this list, even more potent than fentanyl itself. So you go through this, there are conversion factors there. This is something that we could supply if people would be interested after this. As you can see, fentanyl, quick onset, short half-life, 2 to 4 hours. Context sensitivity half-life. This is looking at the differences between whether you're giving an IV push or what we do here, which is putting patients on infusions. Right? Now when you put people on infusions long-term, it changes the pharmacokinetics a little bit. You begin to get kind of what are considered toxicopharmacokinetics. You begin to get accumulation. Hence why now half-life goes up to 200 minutes after 6 hours of infusion, up to 300 minutes after being on an infusion for 12 hours. Changes the game up a little bit, doesn't it? Yeah. Changes the game up. Thankfully, it peaks and plateaus right around 300 minutes. It does. Hydromorphone. So you're looking at a drug that accounts for about 1% of the metabolites for morphine. 5 to 15 minutes. You'll see that the PK profile between hydromorphone and morphine are very similar. Okay. Now the next slide we'll be getting to where you might consider one over the other. Methadone we don't use all that often up here. Sometimes we'll use it to help get patients off their meds, but it does not have nearly as stout of recommendations in the medical population as it does in surgical. So for the sake of time and review. We're going to go ahead and go past that. Now this is looking at whether the drugs have active metabolites, how you do intermittent dosing, how you might do IV infusion rates, and side effects. So I'm only going to point out a few things here that I would encourage everybody to know. Fentanyl is clearly where we go to for our IV infusion, right? It's because it has a short half-life. It doesn't accumulate a whole lot. It has a preferable pharmacokinetic profile. No active metabolites. That's good. That's good. Side effects, you don't have as much hypotension, okay? You do get a little bit of accumulation with hepatic impairment, but it's not enough to really alter the game as we do things here. Now, the one thing I will mention that's not on this list, if you give a large bolus of fentanyl, say 300, 400, 500 micrograms in one fell swoop, right? People will do it. You can get what's called chest wall rigidity, which is unique to fentanyl, okay? That's not going to be good for somebody who's on a ventilator or who might need to be on a ventilator if you just gave them 500 mics of fentanyl. I do not recommend or condone giving somebody that amount if they're not already secured in their airway. It happens. Hydromorphone, as you can see, no active metabolites. Now you're looking at what I want you to focus on in the rest of this is the differences between hydromorphone and morphine. Hydromorphone, no active metabolites. Now, intermittent dosing, this is looking at it probably in a standpoint of a shorter time frame of administration than what we do. You'll see that we usually do 1 to 2 milligrams, depending on the size. Sometimes we'll do 0.5, usually every 3 to 4 hours, okay? 3 to 4 hours. And then if you go back about 2 years ago, I remember going through this, I remember talking to Barb, we had pod 4, it was like an entire pod of hydromorphone drips because we were on fentanyl shortage. You guys remember that? Okay? And we had patients somewhere between 0.5 to 2, we went up to 2 milligrams an hour as a continuous infusion, somewhere in that ballpark. So it's a therapeutic option if patients tolerant to morphine or fentanyl. However, you will have some accumulation, especially in hepatic, less in renal impairment. And last but not least is morphine. As you can see, if we go back, you'll see that both of those drugs get glucuronidated. That's the metabolic pathway. That's the stuff that gets the pharmacist going geeky. Now, morphine, there are actually 3 metabolites. They list 2 of them here. There's 3 and 6 glucuronide. There's also a 5 glucuronide. Not sure why they left it out. As you can see, it's about they did about 10 times the dosing. I'll tell you it's a factor of 5, give or take. Continuous infusion morphine. Where do we use this? Controversial, right? But we will use this in withdrawal of care, all right? And titrate to comfort. It's just difficult. Again, we have probably what would be 5 to 6 different definitions of comfort while we care with withdrawal. Accumulation in hepatic and especially renal. Okay, you have to be careful with morphine and renal impairment, and you get histamine release. Remember, this is the analgesic that we use in patients who have coronary artery disease and ACS. Why? Because it causes vasodilation of the coronary arteries, improving oxygen delivery and adjusting to the increased demand. Non-opiates, all I'm going to stress with this, these guys loved ketamine. It made it at the top of their list. I love ketamine too, I'm not going to lie. It's a good drug, you have to use it in the right population. As you can see, relatively quick onset, shorter half-life, 2 to 3 hours, so somewhat similar to hydromorphone. You do have a metabolite that you have to be concerned about because it is active. The one thing, well, I'll tell you what, hold that thought on ketamine. There's acetaminophen. Please ignore the acetaminophen IV and ibuprofen IV. We have acetaminophen IV. It is restricted. We very rarely will use the NSAIDs like Toradol or ketorolac, ibuprofen, or so on and so forth. And then at the bottom there, you see the neuropathic agents, gabapentin and carbamazepine. I will stress, if you look at this, gabapentin is renally excreted. Okay, so if you have patients who come in with acute kidney injury and they are on 800 milligrams 3 times a day of gabapentin, if that's not caught and changed, I encourage you guys to look at it. Clearly we do as well. If you get gabapentin accumulation, patients will be very, very lethargic, difficult to wake up, and that's not going to work in your favor. They won't have any neuropathic pain, but they won't open up their eyes either. So as far as here, again, dosing ultimately is going to vary depending on how you're using it. But a few things I want to stress with this list. Ketamine, how many of you guys that are here, how many of you have seen ketamine given or used? Okay.
Oh,
yeah.
When we changed.
Yeah, okay, perfect. So as you can see, it attenuates the development of acute tolerance of opioids. We, if you go back to 3 years ago when we used to have an anesthesiologist, Ochbeck here, we detoxed a couple of people. You guys remember that? These sickle cell patients? And phenomenal results. Ketamine is a very interesting drug dynamically. However, can cause hallucinations. They used to call this drug the tiger in the ER world back in the 70s because you would give it and people would basically, it's a derivative of phencyclidine, a PCP, so people would hallucinate. have out-of-body experiences, difficult to control. We've seen it. I've seen it several times in the short time that I've been here. So you can avert this by pre-medicating with a small dose of benzodiazepine. Okay. Now, not everybody believes in that. Not everybody believes in that. Other things to keep in mind for ketamine that's not on this list that I want all nursing staff, physician staff to know, because it's important in this unit. It should not be used in patients with heart failure, especially heart failure exacerbations. This drug does lead to catecholamine surges. Okay, so that being said, you're going to have a decreased norepinephrine reuptake. Okay, that means blood pressures are going to go up, heart rate's going to go up. Probably not the best thing you want to do with somebody with heart failure. Okay. Secondly, anybody who has a documented, known, even if it's treated, psychiatric disorder. Why? Hallucinations. Not good. The rest of these, I'm not going to mention too much. Like I said, I mentioned why we don't do a lot of the NSAIDs. Okay, keep in mind NSAIDs. A lot of these are old school NSAIDs. In other words, they work on prostaglandins that work in our favor versus prostaglandins that are initiated during inflammatory stages. Okay, so unfortunately, keep in mind we have prostaglandins like PGE1 that help provide that protective barrier in our stomach, right? That help dilate our afferent renal arteriole, right? The part of the renal anatomy before the glomerulus. If you're blocking all that, you'll get, eventually over time, you'll get stomach ulcers. That's why you get stomach ulcers with NSAIDs. Now, is that going to happen acutely here? Probably not. But when you have that patient come in with portal gastropathy from liver failure or pancreatic cancer, so on and so forth, probably not the best drug to use. And then when you look at long-term use, even short-term use has been shown to cause changes in renal clearance, okay, because you are going to constrict that afferent arteriole, so probably not the best drug to use in our population. So you can see, gabapentin, I want to point that out again. Side effects, it even has common infirmity, which is great. Sedation, confusion, dizziness, so on and so forth. You can see withdrawal, very uncommon. The seizures is mainly if they're using it as a seizure medication and therapy. Okay, carbamazepine, just one to note, you can see nystagmus with it. Okay, absolutely. Diplopia, lightheadedness. The big ones that I want you guys to know with carbamazepine: aplastic anemia, agranulocytosis, SJS. Okay, and we're not going to do this HLA-B1502 gene. Absolutely not. But there are reasonably good case reports and case series of SJS and TENS in people who get carbamazepine, one way or another. So not only that, multiple drug interactions through hepatic enzyme induction. So as opposed to a lot of drug interactions are because an enzyme is inhibited, this one ramps up 3A4, so it makes drugs get metabolized quicker, not slower. That can be potentially dangerous, especially if it's an antibiotic or some other sedative or analgesic that we're using. That's why I'm not a huge fan. So I'm throwing in my biases in the lecture, I apologize. So administration, as you can see, bolded and italicized, preventing pain is more effective than treating pain. Okay? Administer on a continue or scheduled basis and then supplement as needed. PCAs can be used. We don't use them that often up here. We don't. Plus or minus a basal rate. I'm not a huge fan of basal rate, but I throw it in here just for completeness sake. And then from time to time, I haven't seen this in a while. That's knocking on wood, just so people know. We'll watch it later. Fentanyl transdermal patches are generally recommended against in the ICU. Why? Because we live in a world of Michelin men, okay, and women, right? We have patients who don't have great nutritional statuses, who don't have great oncotic pressures because they're hypoammonemic. That does not work very well with patches, okay? So altered absorption in critical illness. So these are just some examples. As you can see, at the top is level of sedation. Down to the bottom is pain, and then that nice blue area is the perfect world of analgesia. Now, what do you get with PRN? Well, you give a dose because they're in pain. They may fall asleep a little bit. They wake back up and say, "Hey, get back in here, I need pain." They fall back asleep. And that's the patients who can respond. PCAs, well, what happens? The patient presses the button, they fall asleep for a little bit, get drowsy, they wake back up and they start getting in pain, but they don't have to call somebody in necessarily get something. So maybe a little bit better control. And then as you all know, perfect world when you have somebody on a drip, it goes right down the middle, right? Because nothing ever changes. But this is in the ideal world, just to give you guys some examples why we do some of the mechanisms that we do. So therapy goals are to assess regularly, greater than or equal to 4 times per shift and as needed. Administer treatment quickly, no later than 30 minutes after the assessment. And then prevention. Prevention. Pre-procedural sedation, as I mentioned before. Treat pain first, then sedate. There's like the 3rd time. Get ready, it's going to come up more. And I'm going to go through these quickly. These are directly out of the guidelines. This is their this is their pad care bundle for pain. It's basically a lot of the stuff that I just talked about. Assessment, treatment, right, in less than 30 minutes. Notice that it restresses the relaxation therapy. There is like some of the epidural references that I told you would come up. And then prevent, just pre-procedural analgesia, so on and so forth. What may be interesting for assessment, again, Barb, this might be something to look at, is for each of these areas, they have metrics in the guidelines. And some of the stuff is stuff that we already do. Percent of time that our patients are monitored for pain. We can do that, right? We can reconcile that. Demonstrate local compliance. Okay, look at pain scores. For treatment, percent of time ICU patients are in significant pain. You want that percent of time to be as close to zero as possible. It will never be zero. If somebody is reporting zero, they're lying. I won't lie. Percent of time that a patient is initiated within a reasonable time frame, and then as you can see, so on and so forth. It's really looking at ratios in one way or another, and maybe after education, saying this is our goal, this is how we're going to assess it, or basically maybe you want to tell the staff that we're not going to assess it because if you do that, you might run into the Hawthorne thing. Any questions about analgesia? That's the longest section. So I know I started a little bit late. I'm going to tell you right now, I'm going to go past 3. Agitation. So sedatives are commonly used to treat anxiety and agitation. Anxiety, as a definition, is a state of intense apprehension, uncertainty, and fear. We've all felt it at one point in our lives, okay? Agitation, we may have also had this. That is literally the motor restlessness and muscular activity and instance of that anxiety. So up to 70% of patients experience agitation in the ICU. Think about that for a second. Not good statistics, right? Here's I think this is my only animation. I'm sorry. It's a tough balancing act. I want to stress that. So if you can see down here, this is a teeter-totter of over-sedation and under-sedation. So what happens when we get over-sedated and we tip the scale that way? Well, anxiety, agitation, hypertension. I'm sorry. You know what? I have this backwards, folks. The only animation I have, and I have it backwards. This is where under-sedation should be overwhelming. So ignore the animation. It fails. So when a patient is under-sedated, this is when you'll get anxiety, agitation, hypertension, tachycardia, and as you get down, some of the very important ones, myocardial ischemia, that's a big deal, right? Wound disruption, big deal. Patient injury, nurse and MD injury, so on and so forth. Now, watch this because it's going to go in the wrong direction again. This is when a patient's over-sedated, sorry. This is where you get pressure sores, risks for clots, muscular atrophy, especially in the long term. Delayed weaning, unable to assess neurologic function, and increased cost. Why? Because it's increased morbidity. Longer ICU stays, longer hospital stays, longer time on the ventilator. Okay? Not good. This is the only time that it is correct. There we go. The goal is patient comfort and ventilatory optimization. And we have to work on that together, right, as part of a team. So goals: maintain light levels of sedation. As you see, light levels of sedation are associated with improved outcomes, so shorter length of stay. Shorter MV is mechanical ventilation. I just wanted to, because otherwise mechanical ventilation is really long. It takes up a lot of room. Increases physiological stress response, but no association with myocardial ischemia incidents. This is why I tell you it's a little bit controversial. As I mentioned before, the myocardial ischemia is controversial. Depth of sedation and physiologic stress itself, the association between the two remain unclear. So in other words, this is nicely stated. I'll tell you, we're simply not smart enough to put the association together yet. And then the recommendation is to titrate sedation to light, rather than deep sedations, unless contraindicated. And the example that I threw in here is one that we see from time to time, mechanical proning and ARDS. That patient, you want him out. You want him as interactive as this table. Out. Over-sedation in the ICU, this is just showing you a brief study. This is I combined 2 studies into one. 274 patients. 32% of 274 patients, 32%, 1/3 unarousable. Okay? Unarousable. Think about that for a second. And look at these, 2007. It's not that long ago. 32%. 21% had no spontaneous motor activity. Not paralyzed. They were so sedated, no spontaneous motor activity. Little change in consciousness, motor activity, or drug exposure. And only 2% of the nursing staff at these particular institutions thought the patients were over-sedated. That's it. 1/3 of them weren't even arousable. Okay, so again, that comes down to changes in interpretation. Now I will tell you, I want every one of you to hear this, who sees this later on, we are a hell of a lot better than that. A hell of a lot better than that. This is not our institution, by the way. I would not want to be at that institution. So we are much better than that. So, as I talked about the behavioral pain scale, use the most valid and reliable assessment tools here. Look at what I put at top and I bolded. That's what we use, the Richmond Agitation Sedation Scale. Do not use objective measures of brain function, i.e. bispectral index or BIS monitors. Okay? Many of you have asked me about this. We have talked about this when we use it. I will give you more details here very soon. As a primary method, that's important, to monitor patients in non-comatose, non-paralyzed patients. Where does the BIS monitor come in play? As you see in the next bullet point, used to monitor brain function in patients being analgesed and sedated with neuromuscular blockade. That's where it comes into play. As you can see, that's a positive 2B. Excuse me. We can also use EEG monitoring to look for non-convulsive seizure activity. I will promise you, I believe this. This is a biased, but I think the literature agrees with me. We under-recognize seizure activity in the medical intensive care unit. And I mean that globally across the country. We probably have patients who are intermittently or maybe even continuously in non-convulsive status epilepticus that we don't recognize because there's no good trigger to recognize. Right? There's no good trigger. This is just an example. Thankfully, they picked 2 scales, but here are some of the different scales of sedation that have been validated across the world. Some of you may have heard, GCS, right? GCS, we do it here, but keep in mind it's only validated in TBI patients, okay? But we have been, it's extrapolated in most other populations. The other one, some of you may have heard of the Ramsey scale. Ramsey scale's been around for quite some time. SAS is, if you go back, sedation analgesia scale are the only 2, so that's why I put those 2 in the center. So RAS and sedation analgesia scale. And then this is the one we all know and love. You guys, as you come in, new folks who see this down the line, become intimately familiar with this. This is the Richmond Agitation Sedation Scale. Curtis Sessler, back in 2002. It goes from a -5, which is unarousable, up to a +4. You will recognize a +4 if you haven't seen it by now. Our goal was somewhere between -1 to 1 in most of our patients. That's about all of us in this room. Light sedation, -2 is perfectly acceptable. The only exception, again, keep in mind, is that patient who's going to be prone in a rotor-prone bed, you're spinning them around, you want them to be deeply sedated, if not completely unarousable. But keep in mind, go back to that previous study, unarousable is a RAS of -5. 2.6% of nurses. They're okay. They're in light level sedation. Like I said, thankfully you guys are awesome. You don't see that. Bispectral index. So this is a tool that we have to get from anesthesia. All right, they use these in the OR. They're basically a 1-lead monomorphic EEG. Okay, as you can see, the picture there on the right, I guess as we're looking at it, is how you apply the lead. And on the left, that is what the screen looks like. As you can see, there's an SQI, just like there is in some of the other tools we use. That's a signal quality index. You want to have a good signal. Okay, suppression ratio. And then, of course, the trend window and EEG window is what you'll pay attention to as well. That score up in the upper right-hand corner, upper left-hand corner, that 68, is important. Why? Well, this guy, this Robert Kelly here is a big name in this. But as you'll see, number 1, they have in seconds what you would expect with certain BIS readings. Okay, so 100 is what I think all of us are right now, unless I'm boring you. 100 is awake and responding to normal voice. Okay. Down to 20, burst suppression, right? Burst suppression is what we may look for in a patient who is in convulsive, non-convulsive status epilepticus that we're trying to do burst suppression in, okay? So, again, where would we use this? Well, in a patient who is in a rotor-prone bed that we're paralyzing, we want to make sure that they're sedated, especially if they were difficult to sedate analgesics before they got put in the rotor-prone bed. Okay, so where do you want it? Probably somewhere between 30 to 50, somewhere in that ballpark, maybe up to 60. So as you can see, 60, general anesthesia, low probability or of explicit recall, unresponsive to verbal stimulus. Okay. What I will stress, every time this is used, in every ICU, not just this one, people ask questions. Let me make this clear. This is used to monitor brain activity, i.e. it's encompassing sedation and analgesia in patients who are paralyzed. That is what we use it for. I've heard other staff try to explain it. Please, if you have questions, ask somebody. Ask somebody if you're unfamiliar, because I have, in passing, heard it explained before and explained incorrectly. So sedative choices, strategies using non-benzodiazepine sedatives may be preferred, okay, to those using actual straight benzodiazepines. So non-benzodiazepine sedatives include propofol, dexmedetomidine. That leads to improved outcomes of mechanically ventilated patients. That's been stemmed by a couple studies done in 2007 and 2009. Choice can be driven by patient-specific indication and goals. You may need benzos, right? Alcohol withdrawal patient, you may need benzodiazepines. The pharmacology of the drug, right? We use propofol because it's short-acting, right? We don't use diazepam in everybody, right? Because it lasts too long. And an overall cost associated with particular sedatives. This is a reason why we don't use dexmedetomidine in everybody, right? Number one, because it's a wakeful sedation. Number two, because it costs an arm and a leg. And if we use this in every patient, I would get fired. Please don't get fired. This is also coming from the guidelines. It's comparing benzodiazepine versus non-benzodiazepine therapies and ICU length of stay. You can see the studies there. Look at that chart. So the whole purpose of this chart, I'm actually going to explain this one frontward. So sorry, you guys are going to have to see me for a second. The goal with this is, as you can see here, on this side it favors benzodiazepine therapy. On this side it favors non-benzodiazepine therapy. With all of these studies, some of them much larger than others, it all came out to be significant in the favor of non-benzodiazepine therapy. If we look here, it's on here somewhere, the p-value for overall effect, 0.04. Remember, in most studies, a significant p-value is considered to be less than 0.05. Sorry guys, Mike, can you do me a big favor? Return this. This is a pharmacy. Tell them that I'm giving a lecture, and I'll call them as soon as I get done. But since it's being taped, I can. If it's urgent, you can get in touch with Megan Welch. So does that make sense? Everybody, excellent, excellent. All right, so these are some of the agents: midazolam, lorazepam, diazepam, propofol, and dexmedetomidine. Ketamine can also be used as a sedative, for what it's worth. What I'm going to stress here is you're going to see respiratory depression is relatively frequent, okay, especially with the benzodiazepines. That's why you have, especially as they accumulate, right? You've all seen patients we put on drips for weeks at a time, right? Sometimes at least days. We have a couple examples of that in here right now. You turn it off, they're still sedated for days, right? Sedated for days. So what you also see, unfortunately, midazolam, hypotension, you can see. Midazolam is lipophilic, it likes fat. In other words, if you have a little bit of extra weight, like I do, it will accumulate, and if you remain catabolic, which most of our ICU patients are, it'll take time for that drug to clear, days after you stop. Lorazepam and diazepam are both unique because they are actually suspended in propylene glycol. That's something that's important because you can see they're glycol-related acidosis. So if you have a patient, in particular on lorazepam drips, i.e. our alcohol withdrawal delirium patients, they can get osmolar gaps and present just like a normal metabolic acidosis patient, okay? And that leads to nephrotoxicity and acute kidney injury. Propofol, just keep in mind, my bias, the one thing I'm going to encourage you all to do and advocate for, we have patients who are on propofol way too long, okay? Way too long. It's technically a general anesthetic. It is a sedative, but it's not really intended to be used longer than 2 or 3 days. And we've all seen it used longer than 2 or 3 days. If you get to that 48-hour, 72-hour mark, send off a triglyceride level, okay? Just to make sure, because remember, it's suspended in lipid emulsion. Okay? And the dexmedetomidine, we don't use it all that often. It's a wakeful sedative. This is the one that you can walk in, say the patient's name, maybe snap your fingers, they'll wake up, you speak to them, you walk back out, they fall back asleep. So if you need a deeper level of sedation, this one is not the one to go with. Okay. Plus, side effects wise, bradycardia, hypotension. I will tell you the first 3 patients that we tried to use this drug in the MICU failed because of bradycardia. Failed. Okay. Hypotension is normally seen if you give a bolus beforehand. As you can see, you can give a bolus. I don't recommend it, ever. Now, the other thing I will say prior to moving on from this slide is you'll see the maintenance dose is 0.2 to 0.7 micrograms per kilogram per hour. Note that it's per hour, not per minute. That's the package insert dosing. That's FDA approved. I will tell you that we go up to 1.5 micrograms per kilogram per hour because that has been studied safely in patients. I'm not sure why the FDA has not changed their ruling. That being said, the higher you go in dosing, the more you likely take that risk of bradycardia. All right, so just like with pain, we talk about therapy goals. What about agitation? Depth and quality of sedation should be routinely assessed in all ICU patients. RAS done greater than 4 times per shift and as needed. Does that look familiar? Pretty much like the pain. Target lightest possible sedation level and or use daily sedative interruptions. Daily. Daily. And again, unless they're spinning in a rotoprobe bed. Use sedation protocols and checklists to facilitate management. We do that. We do that. We put a lot of work into that. That being said, you have to make sure that they're advertised, right? You guys are all aware of it because you're here all the time, right? But, as Dave mentioned, Dr. Norton, sometimes we have attendings who are only in here 6 weeks out of the year. They may not see this stuff as much or have the familiarity. And then suggest analgesia for sedation for intubated patients and mechanically ventilated patients. There it is again. That's what, third time? Fourth? I can't remember. I lose track. And then this is that bundle again. This is basically what we discussed. Set up a RAS goal when in your assessment. Go through. Notice the different derivations there depending on the scores. Target sedation. So again, RAS -2 to 0. Sometimes we'll do +1 to 1. And then again, for the deeper sedated patients, -4, -5 would be unreasonable. And then prevent. Consider daily spontaneous breathing trial. Okay, so that's what SBT stands for there. Early mobility and exercise when patients are at goal sedative levels. Okay, and again, unless it's contraindicated. Unless it's contraindicated. EEG monitoring can be done if at-risk procedures. And then these are the metrics again. This is just again looking at percent of time the sedation assessments are done. For example, for assessment, for treatment, percent of time that a patient is either optimally sedated or successfully achieved target sedation. Okay, so on and so forth. And then prevention, percent of failed SBTs due to either over or under sedation, because both can comply with that. So these are areas when we talk about research, when we talk about evaluation of how we do this, these are areas where we can look at. And they're easy for us to get, right? And could be comparable, studyable, and publishable. All right, so delirium, this is the last section. So, delirium and outcomes. What do we have with delirium? Well, we know increased mortality. Notice, A. There haven't been a whole lot of A's that I pointed out, right? Prolonged ICU and hospital length of stay. A. Not good. Strong levels of evidence. Development of post-ICU cognitive impairment in adult ICU patients. This is a B, so not as bad, right? But still pretty strong. This name that you see down here, that's Wes Ely. I think Dave Norton has a man crush on Wes Ely, and that's now stuck in time with that camera. This is a study that he did back in 2004 to show delirium and no delirium, and this is what's called a Kaplan-Meier curve to show differences in mortality. 6-month mortality, longer hospital stay. As you can see that the patients who were not delirious, mortality over the course of that 6-month time frame was about 82%. If you look at those who actually did have noted delirium, you'll notice that line approaches 60%. So 20% plus difference in mortality. That's a big deal. That's a big deal. Monitoring, recommend routine monitoring. Look at that. Comes up again. Utilize most validated and reliable tools. A, there it is. Confusion assessment method for the ICU. Yes, that's what we use. Another tool that they also recommend is the intensive care delirium screening checklist. Now, IDISC, that's what I call it, IDISC. I know there's another C in there, but it's one that other institutions are using, but most institutions use CAM-ICU. Okay? Routine monitoring is feasible in clinical practice. They made this recommendation and statement because a lot of people say we can't monitor delirium. We can't monitor, and then studies that have been more recently done have shown that it is something that's important and it needs to be done every day. Hence why I told you guys multiple times a day. That's why I said go back to the second or third slide where I had the pyramid. Delirium is not just the tip anymore. It's a much larger component. Assessment tools, this should look familiar to most of you. The confusion assessment method of the ICU, rapid bedside instrument to accurately diagnose delirium. It can be completed in about 2 minutes, right? Now there's some variability depending on, sometimes you can just walk in and you have inattention, check, right? And you walk out. But yeah, 2 minutes, every once in a while it'll be longer, right? But a very quick tool. So notice you need 1 acute onset of mental status change or fluctuating course and attention and either disorganized thinking or altered level of consciousness. So, can elephants fly? Do rocks float on water? What is this? Right? Save a heart, so on and so forth. You guys do it much more often than me. Okay? I will tell you there's going to be one day, if I ever have to answer that, I will say limestone can float, and I'm not delirious. Sorry. Delirium, risk factors. So there are 4 baseline risk factors defined and derivated by the guidelines. Number 1, pre-existing dementia. Okay, we're finding out that this is more and more of a reality. Okay, as we have an aging baby boomer population, right? So incidence is going up because number is going up in age sections. History of hypertension. That is virtually every single patient who comes into this unit at one point or another. They may be in septic shock, right? They may be in hypovolemic shock. They may be in cardiogenic shock. But I bet you if you look at their med list, somewhere there's an antihypertensive. So the better majority of our patients. History of alcoholism. I'm not going to say anything else on that one either. High severity of illness on admission. Where do we get the sickest patients in this hospital? Better yet, where do we get the sickest patients in the entire tri-state area? Right here in this unit. So as you can see, when you look at baseline risk factors, it's not uncommon for us to easily have 2 out of the 4, if not 3 out of the 4. Dementia is, like I said, probably underappreciated. Coma itself is an independent predictor of delirium, okay? Sometimes we induce that coma, a iatrogenic coma, right? Conflicting data regarding opioid use and onset of delirium. Benzodiazepine use. Notice it's a B, right? Benzodiazepines, I think I have that's my next slide. This Pandarapandi is a guy down in Tennessee. This is cumulative daily dose and the probability of transitioning to delirium. Now what you'll notice is the probability to transitioning to delirium for these patients was almost 60% at baseline. But as you can see, when you get to 24 milligrams in one day, you buy it. They're going to be delirious. They're going to be delirious. So that's just a point I would like to stress to you guys. That's all it takes. That's all it takes. Prevention. Here we are about prevention again, right? How many times? You don't hear a whole lot about prevention. They really stressed it in this group. Perform early mobilization whenever feasible. Some institutions are getting patients on exercise bikes while they're on ventilators, right? So on and so forth. They're doing it. Get them up and walking on maybe non-invasive positive pressure ventilation. Maybe invasive. No recommendation regarding pharmacologic prevention. That's big. None. No compelling data to discriminate or to demonstrate reduced incidence or duration. Does not suggest administration of haloperidol or typical antipsychotics. Whoa, we do that all the time, right? Big deal. No recommendation regarding combination of non-pharmacologic and pharmacologic treatment. The best mainstay of treatment is non-pharmacologicals. Best you can. Best you can. What can you do? If they have glasses, get the glasses on. If they have hearing aids, get the hearing aids on. Now I will tell you, there's a study just published this last month, now that it's August, last month in critical care medicine that say windows don't help either. And guess what the primary patient population was in that study? Medical intensive care unit. So that was one other tool that's now been taken away from us. Yeah, getting a lot of looks and you're like, what? Yeah, unfortunately that study showed that they do not improve delirium or length of stay. No published evidence favoring haloperidol treatment reducing duration of delirium. Package insert, not an indication for IV or PO haloperidol. Atypical antipsychotics may reduce duration. Notice that it's a C. There are some studies out there, but they're generally small sample studies. Do not recommend the use of rigastigmine, right, or any other acetylcholinesterase inhibitor, and recommend against antipsychotic use in patients with significant risk for torsades, right? So we have everybody on tally. We follow QTCs routinely. And that's where you're going to hear me say, I don't know if we want to give that patient 10 milligrams of Haldol. Their QTC is 610 milliseconds, so on and so forth. So I did throw this in here just for information. Haloperidol, rapid onset, long half-life. You do generally use it for intermittent dosing IV. Some places are trying to bring it back as a continuous infusion. We'll see. Adverse effects, this is important depending on where you practice. Dose-dependent QT interval prolongation, mainly with the IV form. You'll see it with PO as well, but that's unique to the IV form as far as amount that you get per milligram you give. EPS, extrapyramidal symptoms, are rare with the IV form. That's more with PO. We don't use PO here. And you don't get the respiratory depression. All right, here's the PAD care bundle of delirium here. Again, assess Q-shift and PRN. With the KMICU, we do that. Treat pain as needed, right? Because that goes back to pain being the crux and center of most of this. Reorient patients, get their hearing aids in, get their eyeglasses on, so on and so forth. Avoid benzodiazepines unless they're alcohol withdrawal patients, and then prevent, as we've talked about. Prevent, prevent, prevent. And then metrics, again, all of these are coming down to percentiles of how often all of these are done and how well they're done, okay? Putting it all together, so we are finishing it. It's going to be probably about 6 more minutes. Is that okay? Okay. Daily sedation interruptions or light sedation levels should be used routinely in mechanically ventilated patients. Plus 1B. Analgesia first sedation, just because I haven't said it quite enough, right? Promote sleep by optimizing environments. Use strategies to control light and noise if you can, okay? Clustering care activities, okay? Right? If you go down, I will never forget this. This is more of an SICU thing, but they used to have the most odd times to give their patients baths. It's like 4 o'clock in the morning. They finally changed it. Bryce Robinson, who's one of the surgical attendings down there, if you guys met Bryce, he used to call it the death bath. Why? Who the hell gets bathed at 4 o'clock in the morning? The last thing I want is to get woke up at 4 o'clock while I'm already delirious on a ventilator and have somebody scrub me down, so on and so forth. What is there? Do we have a set bath time here?
No.
Okay.
No, but night shift tries to do everybody that's intubated and sedated.
Really?
Yeah.
Yeah. So that's just one thing to consider. I will tell you that they change their time one way or another, and it may just evaluating the time. Make sure that it's not happening at 0400. Try to get it at a different time, 10, 11 o'clock, so on and so forth, depending on assessments. So that's potentially something that we can talk about. No specific modes of mechanical ventilation change difference in outcomes in any of this, okay? Use, and I noticed not just italicized, but I made it yellow for emphasis, because this is all of us. Interdisciplinary ICU team approach that includes provider education, what we're doing right now, protocols and order forms, we have all those, and quality ICU round checklists. That has Dave Norton's name all over it. Reorientation. So again, this is a gentleman, Kress. He, I believe Kress is in Chicago, if I remember right. Hold sedation. So what do they do here? Reorientation, sedation interruptions, right? We try to do this, right? We could probably do a little bit better at times with this. Some of it comes down to who may be on surface. Hold sedation, what they do in this study, well, they held sedation infusion until patient awake, then restarted at 50% of the prior dose. That's a novel thought, right? That's incredible. Then awake for these patients was defined as 3 of the 4 following: opening eyes in response to voice, using eyes to follow investigator on request, squeezing hand or sticking out tongue on request. Sometimes you don't even have to request that to be done. But as you can see, again, it's another Kaplan-Meier curve. The interventional group, much better, much shorter stay than the control group that remained sedated and did not get restarted at half the dose. So that may be something to consider, okay? Notice, this is not new thought. This is not new thought. 2000. This was done in 2000. So fewer diagnostic tests to assess change in mental status, no increase in rate of agitation-related complications or episodes in patient-initiated device removal. That would be awesome, right? And no episodes of PTSD or cardiac ischemia. That's big stuff. All right, so something maybe to consider. ABC trial, this is Gerard and Lancet of 2008. I put this one in here because it's one of the more prominent studies done to show the benefit of not just doing spontaneous breathing trials, but also doing spontaneous awakening trials. So you're going to see SAT and SBT. Outcomes they evaluated in this, using this protocol, was ventilator-free days, duration of mechanical ventilation, ICU and hospital length of stay, duration of coma or delirium, big deal, and long-term neuropsychological outcomes. Okay? This chart speaks for itself when you look at this. Ventilator-free days, spontaneous breathing trials compared to spontaneous awakening trials plus spontaneous breathing trial, shorter days and just the spontaneous breathing trial. Time to event days, successful extubation, it was actually in favor of spontaneous awakening trials. Okay? Same with ICU discharge and hospital discharge. All of those numbers are statistically significant. And that's a big deal. 4 less days in the ICU, big, big deal. So I want to take a step back because I misspoke. Spontaneous awakening trials and spontaneous breathing trials were in favor. That was in their favor. They were longer times off the vent. Death at 1 year, check that out. 44% versus 58%. That's a big deal. Big deal. And then coma, looking at brain dysfunction, far less coma when you look at percentiles, and delirium about the same. So no change in delirium, unfortunately, in doing that. Nurse-driven. Look where this study was done. UCMC, Bryce Robinson. This was 2008. Actually, one of my good friends was on this paper, one of my good pharmacy buddies. Not Eric or Neil was on this study as a student. Not to segue, but as you can see here, control group of 61, protocol group of 58%, and look at that job. Okay? I show this because it shows that you guys are all capable of doing a great job in facilitating patient care, right? Duration of mechanical ventilation was reduced, okay? And guess what? These protocols are basically the same as what we're using up here in driving. 28-day ventilation-free periods. Look at that, okay? The protocol group, much better statistically. You look at that overall, 4 days. ICU length of stay wasn't statistically significant, but guess what? If I can almost take off 2 days, 5.9 to 4.1 days, that's pretty darn good. I'll take it, all right? The hospital and finance people will take it, I promise you that. And then hospital length of stay, squeezed in the statistically significant, 6 less days. That's good. So I show this because the goal with all of this is to empower you guys. Why? This is stuff that you guys do every day. Every day. So conclusions. Consider pain, anxiety, and delirium as causes of agitation. PAD goal, so that's, remember, PAD is pain, agitation, delirium. To finish this up, is to assess, treat, and prevent. And again, as you can see, I prevent. It's italicized. it's yellow. Utilize validated assessment tools. Okay, we do that. Maybe we need to reconsider getting away from OPAS and VAS and talking about behavioral pain scales, so on and so forth. That's something that can be discussed. Pain control always first. There it is. Even on the last slide, I can't get away from it. With light sedation levels if needed. Incorporate routine or daily sedation interruptions where appropriate. Again, you're not going to do this in that person who's coming in with, you know, H1N1 flu that's being rotor-prone on a bed. You're not going to do that. And then last but not least, keep it multidisciplinary for the best outcomes. No matter where you look, whether it's ICU literature, non-ICU literature, when we all work together, nurses, pharmacists, physicians, RTs, right, social workers, so on and so forth. When we all work collaboratively, better outcomes for patients across the board. It is no different in the management of pain, agitation, and delirium. That's all I've got for you.